for standing by. I'd like to welcome you to our webinar, The Risk Adjustment Rallying Cry. My name is Sean Forster, and I will be the moderator for today's discussion. Before we get to our presentation, we do have a few housekeeping items. During the presentation, all participants will be in a listen-only mode, so there's no need to mute your lines. Although the lines are muted, we do encourage you to ask questions throughout today's presentation. To do so, simply submit your questions using the questions window located on the right side of your screen. Type your question into the box, click send, and they'll be sent directly to me to queue for the Q&A session we will host at the end of the hour. Should you encounter any technical difficulties during the webinar, please also utilize this window to describe your issue, and one of our support staff will follow up with you to troubleshoot. Today's webinar will also feature 3 polling questions. When we get to the polling questions, I'll pause our speaker to read out the question and give you a minute or so to respond. We'll then share the results with everyone gathered here today. And in case you were worried, no responses will be shown individually. We roll them up overall, so feel free to be honest on there. You're not going to be at risk of sharing anything. Our speaker today will be Tom Peterson. Tom brings more than 25 years of experience in healthcare. Prior to joining the SCIO team, Tom was the CEO and co-founder of Clear Vision Information Systems, which SCIO acquired in 2016. In this role, he helped design the software and services to optimize care and revenue for plans and providers across the country. Tom brings a unique perspective to revenue and care optimization, having held positions both at major health plans, such as Blue Shield of California and Blue Cross California, as well as providers such as Cedars-Sinai Medical Center, located here in Southern California. His background in clinical data related to risk adjustment, system design and analysis, provider outreach, and training program development led to his involvement in the Industry Collaboration Effort, or ICE. In his role with SCIO, Tom leads the operations in our Westlake Village office, overseeing the strategic direction and IT innovation to ensure alignment with evolving industry needs. And here's our agenda for today. When we started putting this presentation together and thinking about what to include, we kept returning to this concept that in healthcare there really are some programs that are so fundamental to an organization that they impact just about every team. But for one reason or another, we feel although risk adjustment is one of those programs, it can oftentimes be relegated to a single department, or even, depending on the size of an organization, an additional responsibility tacked on to someone's day job. So in this presentation, we're going to first quickly cover the background on how we got to where we are at today and kind of that limitations of the single department approach. We're then going to highlight 5 additional departments that we think have a place at the risk adjustment table. Listed here: quality, member engagement, finance, provider relations or contracting, and technology. This list will invariably vary by organization, individuals within, but these are 5 that we see an opportunity with most frequently. We'll then have 2 kind of best practice sections. First up is design an effective risk adjustment program, and the second is going to be on how to foster that positive collaboration between payers and providers, as we have both sides of that equation represented here today on today's call. And then, of course, any remaining time we have, we will open up for Q&A. So again, please submit those questions to us as you think of them. And with that, I'm going to turn things over to Tom to get us going. Tom?
Thank you. Excuse me. So to get started, I think it's always important to understand, where we've been, the evolution of risk adjustment, and where we sit today. So I was fortunate enough in 1997 to be working for Blue Shield of California when the Balanced Budget Act was passed, which required CMS to come up with a new risk-adjusted methodology to reimburse Medicare Advantage plans. And so I was lucky enough to be a part of a team that was able to design something that never existed before. And for those of you who've been in the industry for many, many years, when this was first implemented, CMS was only looking at inpatient claims. So they wanted the diagnosis code from inpatient claims in which the length of stay was greater than a day. Then as we moved forward, there was enhancements to the data. So they began collecting physician data, and again, more changes in 2017, where the risk adjustment payments were shifting and changing, and then into 2008, we folded in demonstration plans, and today, we have RAPs and EDPS that are feeding the reimbursement model, and it's become more complex and more of a challenge, but nevertheless, it's something the industry has to deal with on a regular basis, and this is really an area where we don't compete necessarily. We work towards the same goal of optimizing revenue to ensure that we, as an industry, can offer the best benefits possible given the reimbursement levels we attain. And so today, what we've seen initially was a task that was on one person's desk has exploded into a multifunctional interdepartment task where there's many, many players involved to support the initiatives today. So as we look at the challenges in succeeding in risk adjustment, and this pertains really to any kind of reimbursement methodology that utilizes clinical data from your organization. So any one of these or a number of these can have negative impacts on, of course, risk scores, as well as any kind of quality reporting that you're involved in, whether it's HEDIS, STARS, P4P. Not having the correct coding, having gaps in care, if you're having challenges just collecting the data in some cases, these are all things that are common to the industry. We're well aware of them, and we need to work together to overcome those challenges. And hopefully today, you're going to see different ways in which we feel are best practices to address these concerns. So stepping back and looking at risk adjustment, so whether you're from the provider side or you're the payer side, these are often issues that we're faced with. In a single department generally equals a single focus. So if you're a claims department, your focus is paying claims timely. If you're a risk adjustment department, your focus is on risk adjustment. Your influence on claims may not be there. You might not be able to influence them because they're measured on a different kind of performance level than someone for risk adjustment. And and being that, this does create the silos that we see in the industry, where departments may get territorial about what they know or don't know, and they feel threatened if somebody comes in to poke around in their particular focus within the organization. So silos occur. And what happens here is that occasionally one area, their change or their strategy is counterintuitive to what you think you need for your area. So in the case of claims and risk adjustment, if you're an area where you're dealing with a lot of capitated encounters, capitated claims, the focus really is on the payable claims, not so much the capitated. So there's a bit of a disconnect there. And of course, then moving on, we have the lack of senior leadership and support for all of these initiatives. We in the trenches who are in this day-to-day, we understand the importance of collecting the right data. We know that our members are getting seen. We know that the care is being delivered. But without that support from the leadership team, often it's an uphill battle. And then lastly, we sort of rounded out with you don't know what you don't know. So in the healthcare world, there are many, many players that have their hands on data as it flows in an organization and out of the organization. And not being aware of some changes coming down in IT that may have an impact on your risk adjustment program, or maybe claims is instituting some modification to their system that may also impact your risk adjustment program. Not being aware of those and having a seat at the table does create this an issue that's hard to foresee because the right parties were not there from the get-go.
That actually brings us to our first poll question of today. We'll go ahead and launch that poll, please. The question we have here, I'm going to start off with an easy one, and that is, what department, quote unquote, owns risk adjustment at your organization? Is it A, a separate risk adjustment department? B, is it a function of finance or revenue? C, perhaps quality is added on to their responsibilities. Is it an executive level project, or E, a shared or multiple department effort at your organization? So we'll give you just a few moments to respond to that. And looks like we've got about 35% of the audience so far. Just a few. Well, let's go ahead and close the poll and share the results if possible. It looks like we have actually a majority, 36%, of shared or multiple ownership of risk adjustment, followed by risk adjustment, which I actually would have guessed would have been the leader. So I don't know if that's surprising to you, Tom, on that it's a shared project for most organizations.
Yeah, well, that's actually nice to see that, because I think 36% is actually a very good percentage, but it would be better if that number was higher. So we have 27% of the people responding saying that it's a risk adjustment department. And while that's great that there is a risk adjustment area who's focused on this, hopefully today's session will help you better understand how you might be able to engage other areas of your company to help assist you meeting your objectives.
Great. Thanks, everyone, for participating in that poll. And we'll move on to our section around what other departments maybe you can get in so it is that shared project.
So the first area we're going to sort of talk about is the quality department. So these are the people who are responsible for measuring and monitoring HEDIS compliance. They're developing processes and policies and so on. And their area of expertise that we see is that they're really good at coordinating with providers. They're involved with doing retrospective chart reviews, and they do serve a multitude of tasks. It's not just quality for HEDIS, but there's overlap into STARS and P4P if you're in an area where there's a P4P program. And oftentimes the challenge that we see for risk adjustment is that the quality people are sort of the recipients of the work that's already been done. So their involvement comes in after the fact. So, there could have been maybe some quality measures or some STARS measures that could have been impacted had they known to do some sort of outreach, but because they come in after the fact, their ability to impact is really limited. And so the opportunities that we see with risk adjustment is helping engage them earlier in the process during the data collection year. And it may include coming up with your own metrics or new goals. So maybe your focus is the breast cancer screening. You want to increase that by 10% this year. And so having a goal like that during the course of the year is important, because at the end of the year, when your collection period is locked down, your universe is locked down, then you're left with working with what you have. But if you have a line of sight into that earlier in the game, you are in numbers. When the universe is locked, you'll have much more robust data to work from. So here's another area that we see that has the ability to influence risk adjustment. So, we're calling this the member or patient engagement department. And so, oftentimes these are the frontline people. They're promoting the company by having conversations with members or providers where they're doing some sort of outreach to ensure compliance and satisfaction. So they really do have a critical role for all organizations. These are the folks that enhance the member experience. So if you're doing surveys, member satisfaction surveys, it's the work that these people do that help influence those survey results. And really, their strength really is they're the face of your organization. And so we need to understand what their roles are and their challenges and how we can support them so that in turn they support your risk adjustment initiatives. And the challenges that oftentimes these people are faced with, especially in Medicaid populations, is the member movement. So sometimes they'll have bad addresses or phone numbers if they're doing outreach. It's a challenge for them to try and get to the right member or right provider if the data isn't accurate. And so that is a challenge. And again, the opportunity for risk adjustment is they do have the ability to influence patient behavior. So, for example, if you have a diabetes program and you've got members who are outreaching folks to get them enrolled in your program, these are people that you can tap into for other areas. Maybe you are focused on breast cancer screening, or you're focused on closing gaps for COPD. So, this is oftentimes an untapped area for a health plan in getting assistance. So now we come to the finance department. And so sometimes these are the people we love to hate because they don't give us the funding that we think we need to have. But we have to recognize that revenue is not a dirty word. In order for every organization to be able to provide the services, it must be adequately funded. And for health plans to enhance their benefits, you have to have the funding. In the competitive landscape that we have today in healthcare, the way plans and providers compete is by benefits and their benefit design. So finance does play a critical role in this. And their strengths really are managing expenses and developing strategies to help departments attain their objectives for the company. And their challenges are oftentimes they're the last people to know about impacts to models, if there's a financial change that's happening in terms of risk adjustment or final payments. And so having them involved in the process can sometimes help you gain support for investment in future endeavors. So if you can demonstrate a good ROI, if we do this one particular initiative, they become the gatekeeper and they can be the influencer to help support your organization or your department to get that funding. So having them involved from the get-go, again, is key. So now we have provider relations and contracting. Every organization does have people who are responsible for this particular task. Their role really is to help manage the relationship to ensure that reimbursement methodology is sound and that it's adequate and correct. And these are the people who, whether you're from a physician group or you're from a health plan, can influence the providers that they work with. If a medical group has a robust reimbursement program and there's some sort of incentives for the doctors, then there's a increased possibility of developing and having a better relationship with those doctors. If you're the plan and you're developing some sort of percent of premium reimbursement methodology or some other incentives, having this person be that voice of your organization, again, enhances that relationship. And the next bullet, collaboration. Collaboration is key in everything that we do. And whether it's here in the office where you work every day or it's at home, collaboration is what makes things work. And ultimately, it's the revenue. We want to make sure as an industry, everybody gets paid adequately. And again, the provider relations people, they can influence us. In the challenge category, oftentimes it's contentious between a health plan and a physician group, and it doesn't necessarily need to be like that. Providers often think that they're being underpaid, or providers think they're underpaid, payers may think that they're being overpaid, or there might be some question whether the provider is being reimbursed appropriately. So the big opportunity here for risk adjustment is to create that transparency and the line of sight into the payment changes and forecasts. So again, if your providers know what your initiatives are, where your focus is, if it's on low-performing physicians or low-performing provider groups, having transparency into what the data reveals and sharing that information, it creates a big opportunity to have impact. Lastly, technology. So these are the people that we want to make them our best friends because their roles impact everything that we do in an organization. So whether it's how incoming data is handled, how do you handle data internally within your own systems, and how is data being delivered to the next entity in line. So if you're the provider group, your relationship with your EDI vendor or your health plan that you're delivering that data to, or if you're the plan, the data that you get coming in from those EDI vendors or those contracted providers, how you handle it inside that plan, then how do you get that data to your health plans? So they have a key role in this area, and they're very good at managing data because that is what their job is. But the challenges here in this new electronic world that we have today is that all you need is one thing to break, and it can impact everything downstream. If for some reason there's an edit that's being applied at the front door and data might be rejected, and if nobody knows about that or nobody's working those rejects, then that means that data is lost. And so having a seat at the table with the IT department helps you have these kinds of conversations. And you can see the visual that's there on the right side of the screen. So this is our sort of description of how the world works in healthcare. I'm not going to go over each one of these, but you can see there's many, many handoffs in the process. And so each step in the process we want to make sure is being handled the way we think they're being handled. And if there's any issues, we have the ability to address them and resolve them. So because we just had Thanksgiving, we thought we would share this. So if you look at the graph, the diagram there on the right, so think of this as a Thanksgiving table. And all of these people are seated at the risk adjustment table. And they all have an impact. They all have a role in helping risk adjustment survive. And having the right individuals, meeting on a regular cadence makes all the difference in the world.
All right, thanks, Tom. That actually brings us to our second poll question of today, and this is as we head into our best practice sections. What % of your patients or members have HCCs documented? This is across your total population. The options here range from under 40%, 40-50, 50-60, 67, all the way up to over 70%. We'll go ahead and just give a few moments for people to respond. And if you don't happen to know offhand, just use your best guess. There's not going to hold you to it necessarily, and there's no complete wrong answer there. So. people seem shy on this one. We've only had a handful of responses here. But let's go ahead and, since we're to keep on time, let's go ahead and close the poll and share the results, please. All right, so it looks like the highest response is around that 40 to 50% range, followed by a couple responses on the 60 to 70, and only, looks like there's probably one or two people that are over 70%. Now, I know this is a key kind of indicator that you look at, so what does that kind of distribution say to you?
Well, typically, the more involved organizations are in risk adjustment, the more people involved, the better the scores. The more transparency you have, the better the score. So, you know, if you're in the 40 to 50% range, you know, don't feel bad. You have company. So the great thing is that there's lots of opportunity for improvement, and the improvement does not have to be costly. It's just really taking a step back, being objective about your organizations, and identifying a few key areas where you can have impact. And over time, you will see these numbers change. Typically, we see members with ACCs over 70% of the population. So a good, robust program, that's the area that we're going to see somewhere between above 70%.
And as you're speaking, I'm realizing I did say across all populations. We mean kind of Medicare Advantage populations where we see those ACCs. If you are including your commercial population, of course, you'd see a lower percentage there. So maybe I was a little misleading in my description there, but at any rate. So it's designing an effective program.
So one of the things that we thought would be useful today is to sort of talk about what we feel are best practices in designing good programs. And, you know, again, depending upon the size of your organization, little pieces and parts of this might fit better than others. So so feel free to use what you think is beneficial for you and toss what you think may not apply. So this particular graphic really is meant to describe this iceberg. So we see what's above the water. This is what we know to be true. So in this case here, we're calling it members with gaps, right? The water level, this is, you know, we have provider-specific concerns. So maybe we can identify low-performing providers and these members that may have gaps that are assigned to these providers. So again, we can see that. But what's below that waterline, we're referring to global process issues. These are things that maybe nobody has any line of sight into. It could be not having a complete understanding of how data flows in your organization. It could be not understanding which providers are not submitting data. It could mean there's a broken process inside your organization where maybe data is not mapped correctly or it's not being exported the way that it should be. So these are all the things that we don't know about. So in the risk adjustment world, you know, we're only able to see, we have a line of sight into the stuff that's on the water edge and above, but we don't have any line of sight below that. But transparency can help resolve that. So as we look at building programs to help manage our risk adjustment work, it's important to come up with some sort of balancing in terms of retrospective activities and prospective activities. So in the retrospective world, you know, this is where we see the chart audits. It's a necessary evil, and it's well worth a while endeavor, but it's important to also be smart about it and be selective on how we do our chart audits. If you're an organization who maybe has a member visit program or home visit program, and you've got certain members who are in that category, then pull them out for your chart audits. If you have some other program that's going on where other areas are doing chart audits for some other purpose, maybe for quality, you want to make sure that you're not duplicating efforts. And the last thing is to share feedback, share the results. So as you're doing these audits and you're finding issues, talk to the providers. If you are finding issues internally, talk to your organization internally. If you've discovered you have some sort of data limitations, again, this is an opportunity for you to begin having some dialogue. In the prospective category, this is really where I think organizations who do a good job at risk adjustment, this is where they invest their resources. So they're looking at all their processes, and they're looking for ways to become more efficient and create the transparency that helps them succeed. And this is the adage of the right hand and the left hand not knowing each other is so true in this area. If you're focusing on a particular task in your organization, yet your health plan may not know about it, or if you're a plan and your providers don't know where they need to focus, then that's a challenge because of the lack of transparency. And integrating risk and quality, they really do go hand in hand. Most often, they are separate areas with separate focuses, just as I mentioned earlier about the claims department having a particular focus. The same thing applies for risk and quality, but it doesn't have to be that way. In fact, we see where people succeed by involving the quality people earlier in the game. So with everything that we do, we need to set goals for ourselves. And our leaderships in all our organizations, they like to see this as well. They need to be able to report out on their activities. And you want to be able to report on your activities and what's working, what's not working. So as you begin to look at particular goals, we use the acronym of SMART. Most of us have ever done a self-review and you had to do some goals. They've always said, set SMART goals. And so it's actually a very, very intelligent thing to do here. So we want them to be specific. So if you're looking at maybe 3 areas in your company, we want you to specify those 3 areas and make sure that it is something that is measurable. It could be RAS score change. It could be decreasing gaps. It could be increase in breast cancer screenings. It could be anything that is pertinent to what you think is important for you to work on. And make sure that they're assignable. So you can say, okay, Bob, your area, this is what we're going to focus on here. Because things will fail if there isn't one person put in charge, and make them accountable. And again, be realistic in your goals. You can't say, oh, I'm going to close 80% of my care gaps in 1 year. That's probably not going to work. You will probably fail at that. And the other item to be aware of is make things time-bound. So goals could be quarterly. They don't have to be annual. You could say, I'm going to increase a reporting of a certain condition by 2% in the first quarter. So make them realistic. And something else is, as we begin to look at developing benchmarks and reporting to see how we're performing, is look at year-over-year data. If you have internal benchmarks or industry benchmarks that you have access to, measure yourself up to them to see how you compare. Benchmarks aren't only items that you develop internally. There's a lot of good information out there that you can search online and find. And another area that I think that is important for everybody to consider as you're going through this goal setting process is to mix quantitative and qualitative goals. And our examples here is a quantitative is a RAS score increase, where the qualitative goal is people who attended a risk adjustment education session. Or, it could be, I did a topic on how to document CHF. There's all kinds of areas where you as your individual area, your companies may feel like this is where we really want to focus this year. So consider both those options. And here's some examples of goals. So if you're new to risk adjustment, or you're a small organization, or you're just starting, maybe your goal could be member visits. So you want to reduce the number of members that didn't have an office visit by 20% in the next payment year. Could also include recapture rate. Over the next year, I want to see a 5% improvement in documenting previously reported HCCs for Dr. Smith. So now we're saying, I'm looking at a particular physician, and I'm going to get them to do better, versus trying to boil the ocean and say, oh, I'm going to get my scores up company-wide by 5%. Well, that could be a challenge if you're new. But focusing on a particular physician in this case, that is achievable. Then moving on to the intermediate category. So chances are you will do the first things in the beginner category. And then maybe you want to look at increasing the prevalence of particular HCCs. Our example here is CHF and COPD. So those are the kinds of things to be looking at. And then finally, the advanced category. So we're assuming that in the advanced category, you've got a handle on the beginner and the intermediate goals. But now maybe you're going to be looking at your RAPS and EDPS reporting rates and looking for discrepancies when they don't match each other. So maybe your goal could be, I'm looking at keeping my discrepancy rate within 5% by the final submission date for EDPS. So again, as you begin to look at your goals, start thinking about it in this context. So here we have something called the 3 rights. Engaging the right person with the right information and at the right time. So we've taken this and we've broken it into 3 categories. Things before a visit, during, and after a visit. And so we've outlined challenges that we see and solutions. So I won't go over every single one of these, but as an industry, everybody has the same challenge. Getting numbers in, making sure that all the diagnosis information is captured, making sure it's all documented, or if there's something that's left, some gap, that we manage that. So again, make this fit your organization. So here's just some sample reports. I'm going to move through this fairly quickly. We have, this is a listing of new members. So we know new members join your organizations. Many of them have chronic conditions that come with them that maybe you are not aware of. The PCP may not know about them. If you're a health plan, your health plan certainly doesn't know about them because you don't have any claims experience on these members. But it's important to identify these people and take advantage of those opportunities during that new member visit to equip the provider with all the right information they need at the time the member's being seen. Now, closing gaps. So now we've identified members who have gaps in care. They could be these new members, they could be existing members. We want to be able to arm the doctors with all the information they need to perform the assessments that need to be done, and of course document them. And so having some sort of documentation for your organization is key to accomplishing that. And one item that I'm going to really focus on here, it is important that your information be current. So if your reporting information is 6 months old, could be from last year, the easiest way to lose engagement is by sharing outdated data. So do your best to get it as current as possible. In another area that I think is good to focus on is looking at your opportunities in terms of closing gaps in care from a financial lens. Now, I understand that here in healthcare, we're about providing care, but as we talked about earlier, revenue is not a dirty word. So this is a great way for organizations to say, wow, this is my opportunity. This is what's being left behind in terms of dollars. So it's important to also look at it from that lens. And then finally, so we've done all this work, we've done chart reviews, we've found some missing data. Now we need to have a way to systematically capture and track what we've done. What we've seen in the past is organizations, they'll use Excel spreadsheets to try and capture this information. They'll send out a team of nurses or chart auditors to go out with their laptops and they'll start dropping in data on a spreadsheet. But what happens with that, like anything else, the more hands involved, the more process and steps you have to aggregate that data can cause issues. Data could get misaligned, you could enter bad data, so it's important for you to look at your organization to figure out, is there a way for us to do this in a way that's repeatable, that's trackable, and in this case here we have a system that also will do edits. You can see these are ICD-10, so this is an old screenshot, but knowing when somebody enters bad data at the time they enter it is key. So now we're back to that risk adjustment Thanksgiving table. So the division of labor is color-coded and is tied to the roles at that table. So suspecting in the risk adjustment world falls into chart review, which can overlap into quality, then member engagement, and so on. And so this is an easy way for you to see where you need to have that cross-functional engagement, where people may be involved, why you need them at the table. So I think this is it's a fairly generic view, but it's a view of a process that every organization has. So whether you're a physician group or you're a provider, whether you're new or you're advanced, everybody is faced with these very same steps. And this is just a visual of how we see the labor divided up. So now we come to measuring progress. So we've set our goals, we've watched our trends, we've maybe been able to calculate ROIs in some cases. We want to make sure that information gets circulated throughout your organization so that you can recognize the people who have made an impact. So this could be possibly recognizing a physician for coding improvement. It could be someone in your team who has helped you focus on member engagement to get members sane. So it's important to understand where everybody sits in your organization and acknowledge their participation and involvement. This really is a team effort. This really does take a village. So these are just some examples we've highlighted here. Wrong way. So scaling yourself. So as you saw on the other slide, or the division of labor, that's pretty much consistent no matter what your size is. But it's also important to understand and scale yourself to the size of your organization. So in the small category, I'm going to work from the bottom and go up. In the small category, we have delivering reporting. That reporting could be paper-based. Maybe it's monthly to some providers, quarterly to others, or quarterly to everybody. But when you're small, this is where you start. And then as you become larger, maybe you're now developing better relationships with your providers and you're delivering information electronically. And then when you get to the large organization, now you really do have a cross-functional team. and you're getting feedback from your providers as well as the folks internally in your organization. So the risk adjustment team can solicit feedback from claims, or get feedback from IT, and IT can get feedback from your risk adjustment team. So you know, this is when you're a well-oiled machine. You know, that's where you should be.
Great. I think that brings us to our third and final polling question of today, and that's, how would you rate the collaboration between your organization and the health plan, or if you are a health plan, the provider groups that you work with? Since we have both, it'd be interesting to see what people respond with. Is it A, needs improvement, B, average, C, excellent, hopefully, or perhaps not applicable if you're don't fall into one of those. So we'll give folks just a few moments to respond. Let's go ahead and close the poll, please, and share the results. Looks like kind of an even distribution, other than average is the leader in the clubhouse with 50%, and the remaining split between needs improvement, excellent, and we have a not applicable as well. So it looks like that's probably about what we'd expect. Average is the average.
Yes.
And so in this last section here that we'll be showing, talk around some ideas around how to foster that positive collaborative relationship between a health plan and provider, knowing that there will always be a little bit of tension, just like any two organizations working together, but hopefully we can get some more alignment and work together to a common goal.
So as Sean mentioned, so we'll talk about collaboration. In every relationship that we develop and we manage and we try to collaborate with, we need to understand their level of sophistication. So is this somebody who needs just risk adjustment one-on-one training so that they can understand what the issues are? Is this somebody who has little technology? You know, sometimes, you know, we work with providers who are still using paper. Oddly enough, it still happens today. And the last piece, the human capital. So not every organization is fortunate enough to have all the right people in the right place at the right time. You know, oftentimes this is a part of somebody's job. You know, maybe it's the person who drops the bills if you're a provider and you're working on super bills. So your use of technology is probably somewhat limited, and your risk sophistication is not there because your job is a biller. So it's important to understand all of these components when you're having discussions with anybody that you're going to collaborate with. So on this slide, it's important to understand, in this case, if you are a plan or a provider, it's important to understand, again, the sophistication. So, you know, on the left side of the screen, you might be new to risk-bearing contracts. So maybe risk adjustment one-on-one or some sort of provider in-service is important, all the way out to you're a 5-star plan and you want to maintain that 5-star reporting, and knowing that CMS moves the goalpost every year and you have to do more and do more to retain that 5-star label. And you're sophisticated in your processes and so on. But what all of these share is the need for one platform to manage the process. It's important to have everybody reading off the same page. And so in this example here, we've got contract 1, 2, and 3. So this could be a provider. You have 3 contracts, and it's important for you to be able to look at that data through a single lens. You know, oftentimes what we hear is contract 1 gives me reports every month, and contract 2, I get them every quarter, and maybe contract 3, they have a portal that I have to go to, but I don't have any time to go there. So, you know, I do very little with contract 3. Or if you're a plan, and you have multiple contracts because you're located in multiple states, again, it's important to have a single look and feel to your data, because as a plan, you probably got these other contracts in other states because you acquired other health plans, and one claim system does not communicate with another claim system. So you have these disparate systems, yet you're collecting data for one particular purpose. And it's difficult to share that information across those contracts without having a single platform. It just really makes a lot of sense. So here's an example, and this is for real. This really did happen. So we had a 65,000 member Medicare Advantage plan. Their goal, of course, is with everybody. They want to make sure they've got the right revenue, so they're optimizing revenue and quality, and they were collaborating with providers. So, you know, while this may say it's a plan, if you're a group, put yourself in the plan's position and think about how you communicate with your doctors. Okay? So their goal was to identify members with gaps in care. So they were focused only on chronic care, certain kinds of gaps. They were targeting low-performing providers who maybe need some sort of education or other support. And then they wanted to be able to deliver good information. We're calling it actionable, but it's good, solid information for the groups to work that was in a consistent format. And what we did with them is we actually developed a three-pronged approach. So we looked at high-volume providers. So the system that they were using at the plan was shared with the high-volume providers. So these providers had a line of sight into the very same data that that plan was viewing. Of course, they were only seeing their piece of the membership, but because they were reading off the same page, it was easy for the plan to have a conversation with the provider to say, this is what I see. Look at member so-and-so, or look at Dr. Smith. So you can have a very effective conversation when you're seeing the same data at the same time. Then we had low-volume providers. And so these were providers who did not have the sophistication, they did not have the time, but it was important for the plan to share reports with these providers or some sort of assessment tools. It could be a listing of reports of gaps in care. But again, it was paper-based. So they were actually pushing paper to these providers. And then we have outlier providers. So these are providers who maybe have low scores or with significant membership, where they offer some sort of education. Risk Adjustment 101. It's easy to do. You know, there's a lot of good information out there to put a Risk Adjustment 101 program together. And the results of this, so there really wasn't a lot of work involved, but they were smart in what they did. So they increased their revenue by $24 million a month. So yes, this might be for 65,000 members, but you know, adjust that down based on the size of your population. These are significant dollars. And they were able to close 38% of the gaps for members with chronic conditions in the first year. So that 38%, that's a great number to have. And so as you're setting your goals, maybe you want to look for something that's half of that. It all depends on what information you have to work with and how sophisticated are you in managing those processes. As I said, these are real results. This really did happen. So here's a few takeaways from what we talked about today. And the first one is really take an honest assessment of your current situation. You know, everybody starts at a different point. As we did the polls earlier, we could see where some people felt they were adequate, they were doing a good job. There were some people who felt that they could improve. There were some people who felt they were excellent at it. And for everybody, you have to understand that you can't necessarily compare yourself to the person down the street because everybody has a different starting place. It's important not to imagine yourself as you're some advanced, sophisticated organization where maybe you're more in the intermediate category. And the next thing is to get all the right departments involved. As you've hopefully seen during the discussion today, the pivotal roles that these other departments play in surviving the risk adjustment and reimbursement arena are key. Just as we collaborate with our providers, we also have to collaborate internally and have that level of transparency so that everybody understands what everybody else is doing. And again, balancing what you do. How much focus you want to put on retrospective work and how much on prospective, and what is your opportunity in both areas. And of course, we talked about the goals. Try and make them smart. You know, set reasonable goals that you can attain. You know, try not to boil the ocean because you will never succeed. The last thing you want to do is fail. So make sure that your goals are smart. And the 3 rights. So the right person, right information at the right time. It's really key to understanding how to succeed is to arm people with all the information that they need and make it at the right time that they need it. If you give a bunch of information to a doctor before members ever come in, I can guarantee you that information is going to sit on somebody's desk. But if you can make sure that that information is given to the doctor at the time he needs it, then you can see them take action. And then finally, we close out with the collaboration piece. It's the payer-provider collaboration really is key to any kind of successful program. You know, again, this is where my comment, it takes a village. It really does. And as a provider, you cannot survive on this on your own without the right support from your plan. And the plan, you can't survive without the right support from your provider. So you really need to understand your partners and work together.
Great. Thank you so much, Tom, for walking us through that. We do have time, I think, for just 1 or 2 questions. We have received a few throughout the presentation, so I'm just going to start at the top and see how far we get in this next few minutes here. So this first one coming in is around, let's see, it probably came from the person that's more advanced along. They're asking around tactics for closing the EDPS discrepancy at their organization. But maybe just so everyone can be involved in this, you could talk a little bit about what we mean by that discrepancy, how you would know if you have one or not, and then maybe to the tactics as well.
Well, I think it's important for everyone to understand that when we're talking about RAPS and EDPS, in the RAPS environment, CMS has been specifically silent on what constitutes data for risk adjustment in the RAPS world. And the instructions we basically got was it had to be a face-to-face visit with a qualifying provider. Well, everybody was left to their own devices as to what did that mean. So in some cases, people maybe were over-filtering. So less data went to CMS. Where they were under-filtering, meaning more data went to CMS than should have. So nobody knew for sure what was right because every organization was doing it based on to the best of their ability. Everybody was trying to do things right. So now we advance into the EDPS world. So in EDPS, it's a very complicated format to begin with. You know, RAPS files, for people who may not know, have 5 or 6 data elements on them, where the ANSI 837 has numerous data elements and loops and segments, and there's lots more opportunity for data to get dropped or lost or rejected. So the filtering logic for EDPS is also different because CMS is now stating what counts and what doesn't. So that information has been made public. So you have a couple of opposing forces here. You've got data that's being filtered through based on the plan's discretion, their understanding of what it's like, how CMS is filtering it, and because of the complexities of the 837, what really does make it through the door. So as you look at this, it's important to understand just because you see something on a RAPS and you don't see it on EDPS doesn't mean that it didn't go. Maybe it did and it didn't qualify, or if it went and it was rejected. And so as organizations, as we look at this, it's important for us to not necessarily think of pointing fingers, but it's really a strategy of uncovering what happened. This is more Sherlock Holmes kind of work than anything else.
Okay. Well, thank you. And if you did submit a question and we weren't able to get to it, and there's a few, we'll follow up with you separately with that information. And with that, I'd like to thank Tom for joining us today, and thank all the audience for taking time out of your day to listen to our presentation. And with that, we'll conclude today's